I want to turn our attention to the shoulder joint, and particularly to deal with the issue of shoulder dislocation. We talked about the fact that the dislocation of the shoulder can injure a couple of nerves, but we want to first talk about why the shoulder dislocates as frequently as it does. It's actually the most frequently dislocated joint in the body. And the reason that it dislocates so frequently is that it's built in such a way so as to be very mobile. And when a joint is designed, it's either going to be designed for mobility or designed for stability, but not both. You sacrifice stability when you increase mobility. And that's how the shoulder is designed, to be very mobile, to increase the range of motion of the hand, but therefore it's not very stable. And when we look at the bony arrangement of the shoulder joint, we see what it is that is so unstable about it. And that is that even though we talk about the shoulder joint as being a ball and socket joint, in reality the socket, or the glenoid fossa, is not much of a socket at all. It's a very small articular surface, and it's practically flat, very close to flat. So you have a big round ball articulating with a small flat articular surface, and that's inherently unstable. It's very mobile, but it's inherently unstable. So the stability that the joint does have, and most of the time it doesn't dislocate. So what is giving it the stability that it has? And the answer to that is primarily the soft tissue that crosses the joint, specifically the muscles and tendons that comprise the rotator cuff muscles. So on this slide, what we can see is one of the rotator cuff muscles, that is the supraspinatus, and we can see it crossing the joint above the shoulder joint, and the tendon, although it's not shown here, the tendon actually blends in with the joint capsule and reinforces the joint capsule. But to get a better appreciation for how the rotator cuff muscles and tendons provide stability to the joint, what we'll do is we'll take a look at the joint standing at the lateral side of the joint, looking in at the joint. We'll remove the humerus and look in at the joint from the lateral side, looking at the glenoid fossa. So we're looking into the shoulder joint from a lateral view. The head of the humerus used to be sitting here. Where that yellow dot is represents the position of the humeral head. This is the posterior side of the joint. This is the anterior side of the joint, superior and inferior. What we can see here is that there's a tendon right here reinforcing the upper part of the joint capsule, and that's the supraspinatus tendon. On the posterior side of the joint, we have two tendons, the infraspinatus, represented by I, and the teres minor, T, reinforcing the posterior side of the joint. And then lastly, reinforcing the anterior side of the joint, we have the tendon of the subscapularis. So those four tendons, supraspinatus, infraspinatus, teres minor, and subscapularis, the mnemonic is SITS, S-I-T-S, are the rotator cuff tendons that are reinforcing the shoulder joint. But notice that provides reinforcement to the back of the joint, the top of the joint, and the front of the joint, but not to the bottom of the joint. So the bottom part of the joint capsule has no reinforcing tendon, and in fact that's also the part of the joint capsule that is the most slack. So the lower part, or the inferior portion of the joint capsule, is the weakest part, and therefore a dislocation of the head of the humerus is most likely going to be a dislocation which the head of the humerus is driven out the bottom of the joint capsule. That's what this arrow represents. So the mechanism of shoulder joint dislocation, which usually involves upward displacement of the distal end of the humerus, which will cause, in sort of a seesaw effect, a downward displacement of the proximal end of the humerus, or the head of the humerus, driving it down against the bottom of the joint capsule, which is not reinforced, allowing the head of the humerus to escape from the bottom of the joint. Now, even though that's true, we know that clinically most shoulder dislocations present with the patient appearing with a humeral head anterior to the joint capsule in the position of this circle. So the shoulder dislocation presents with the head of the humerus sitting here anterior to the joint as opposed to its normal position of here. So the question is, how did it get from here to there? We just discussed how it dislocates inferiorly, not anteriorly. So it ends up in an anterior position by a mechanism illustrated with these arrows. It in fact does dislocate inferiorly in the manner I just described. But with this displacement of the humerus, the upward displacement of the distal end of the humerus, that is to say, forcible abduction of the humerus at the shoulder, there is a natural external rotation that accompanies that. So external rotation of the humerus, when the arm is driven in that direction, will result in the head of the humerus being displaced anteriorly. So we said the direction of the force will force the head of the humerus down and then anteriorly. And then, with the head of the humerus in that position, the injury causes spasm of the muscles that cross the shoulder joint. As those muscles contract, particularly the deltoid muscle, pulls the humerus up. So the head of the humerus is driven down and forward and then gets pulled up, meaning the head of the humerus is now sitting in front of the shoulder joint, typically right under the coracoid process. And that's how most shoulder dislocations present clinically, with the head of the humerus sitting in front of the joint under the coracoid process. That means that a reduction of that dislocation is not possible by simply pushing the head of the humerus back to its normal position, because the anterior joint capsule with the subscapularis tendon is in the way. And so the way to get the head of the humerus from here back to its normal position is to retrace the steps it took to get out. And so downward displacement, posterior rotation of the head of the humerus, and then release to allow the deltoid to again pull it back up into this position. So it's traction, internal rotation, and release will get the head of the humerus back into this position. Now, to get to the issue of nerve injuries associated with dislocation of the shoulder joint, we said that there were two nerves that are subject to injury. One of them was the axillary nerve. And so if we put the axillary nerve into this picture, the axillary nerve, recall, sits right up against the surgical neck, which is right here. But it also means it's sitting right under the joint capsule. So a downward displacement of the humeral head is going to stretch the axillary nerve. So that's why the axillary nerve is subject to injury. And then sitting right next to the axillary nerve, on its way to that spiral groove that the radial nerve passes in through the arm, there's the radial nerve, also sitting below the joint capsule. So again, a downward displacement of the humeral head can put traction on the radial nerve. So it's the position of the axillary nerve and the radial nerve right under the shoulder joint capsule that results in them being subject to injury with a shoulder dislocation, because the humeral head tends to displace inferiorly out of the shoulder joint.